Hello, my name is Mervyn Singer and I'd like to talk to you about some tricky cases with COVID-19 disease that presented interesting circulatory problems. So COVID-19 is a disease we haven't previously encountered. These patients predominantly present with lung dysfunction and a high proportion develop an ARDS type picture. However, the degree of thrombosis, of pulmonary emboli, are much higher than that normally seen with ARDS, and this point was emphasized quite impressively in two studies here, one from France, one from the Netherlands, where there was a very high degree of thromboembolic complications, and the patients with COVID-19 ARDS had a much higher incidence of pulmonary embolus compared to those with standard ARDS. These studies highlight the number of patients in whom COVID-19 disease-related thromboemboli had been detected clinically. However, many patients likely have undetected microemboli or smaller emboli, and this is exemplified by this study from Italy, where postmortems were taken in patients dying at two centres, and in only 13% of cases were microthrombi or even bigger thrombi in the lungs not seen. The corollary of this is that many patients with COVID-19 disease likely have pulmonary vascular problems, and that will cause pulmonary hypertension, right ventricular strain, and in a high proportion of patients, right ventricular failure that may compromise their circulation and their gas exchange. So the first case report I'd like to talk about exemplifies this sort of problem. This was a 62-year-old male who was previously fit and well, apart from some mild hypertension. He presented with increasing dyspnea. To the emergency department, he was alert, although he was tachycardic, and on room air, his saturations were very low at 76%. An echo was performed soon after, and that showed a moderately dilated right ventricle and poor contractility. A pulmonary embolus was queried, so he was taken for a CT scan, and that indeed confirmed a large saddle embolus. Unfortunately, at the end of the procedure, he had a sudden cardiac arrest, a pulseless electrical activity arrest. He had CPR, and fortunately his cardiac output was restored within a few minutes after one dose of epinephrine. Thereafter, he was stabilized on high-dose norepinephrine by infusion and given atelectase as a thrombolytic. He was then transferred to the intensive care unit. When he arrived, his oxygen requirement was high, about 80%, and that gave him a PaO2, an arterial oxygen tension, of 8.5 kilopascals. That's just over 60 millimeters of mercury. He was tachycardic, blood pressure was adequate, though he was requiring a high dose of norepinephrine, 0.65 micrograms per kilo per minute, and he had a very high lactate of 6.4. Clinically, he was peripherally shut down, he was very mottled, and he was passing very little urine. A Doppler probe was inserted, and that showed some interesting features. He had a very low stroke volume, 15 mils, and a correspondingly low cardiac output of 2 liters per minute. He had a very narrow corrected flow time of 150 milliseconds. The normal range is about 330 to 350. So this implies he was very vasoconstricted, and there was a very big swing in peak velocity, ranging from 40 to 80 centimeters per second across the respiratory cycle. So while the higher peak velocity is compatible, normal for someone of his age, there was still this big respiratory swing, and he was requiring a high dose of vasopressor. So clearly he had a good reason to have underfilling of the left ventricle from the large pulmonary embolus and obstructive shock. However, it's important to also consider a concurrent hypovolemia component, because in pulmonary emboli, massive pulmonary embolus, there's a need to make sure the right heart is adequately filled, not overfilled, but adequately filled. The quickest way of challenging this is to do a straight leg raise. You get an instant result, and there was an improvement in his hemodynamics by lifting the patient's legs up and then giving an endogenous fluid challenge. This showed he was fluid responsive, and so he had a 250 ml fluid challenge given over 5 to 10 minutes. There was improvement, and so that then encouraged further challenges with assessments of his hemodynamics both before and after each challenge. So by 90 minutes, he'd received 2.25 litres of fluid, by which time the norepinephrine dose had come down about 75%. His blood pressure was maintained and his stroke volume was considerably better. It had improved from 15 mils at the beginning to 57 mils. The heart rate was lower. The cardiac output was much better at 5.2 litres per minute, and the corrected flow time had improved with the administration of fluid and the reduction in pressors, and now was in the normal range at 342 milliseconds. The peak velocity was in a normal range, and there wasn't a respiratory swing. The lactate level had normalized, and he was now passing urine. So this low stroke volume was identified to be related to reduced left ventricular filling. There were the signs, the features on the Doppler trace, the low corrected flow time and the low stroke volume, with a relatively preserved peak velocity and a big respiratory swing. And giving this volume challenge, elevating his legs, showed the improvement in stroke volume and blood pressure, which showed he was fluid responsive. So therefore it was appropriate in his situation to try fluid challenges, and rather than just giving a huge amount of fluid in one go, you can titrate the fluid to restore an adequate degree of organ perfusion, yet at the same time not overload the patient. So you can titrate fluid precisely to optimize circulatory status. The final case I'd like to describe is of a 55-year-old male who was obese, diabetic, hypertensive, came in dyspneic, tachypneic with a rate of 35 breaths per minute and a saturation of 82% on 100% oxygen delivered by face mask. He initially improved on CPAP, but 12 hours later became CPAP mask intolerant, agitated, so required intubation and mechanical ventilation. He needed high levels of sedation and overnight became more unstable from a hemodynamic point of view, with hypotension, a blood pressure of 78 systolic, but a normal lactate level. He was started on empiric vasopressors and the Doppler probe was inserted. He was on rather high ventilator settings. He was on pressure control ventilation with a peak pressure of 28, which was 14 above the level of PEEP. He had a rate of 24, an IE ratio which was inverted, so this was at 1:1, and that generated a tidal volume of 410 mils, yet he was needing 90% oxygen to deliver saturations of 88%. From a physiological point of view, he was tachycardic, the central venous pressure was high at 15 millimeters of mercury, and the blood pressure was adequate, though he was requiring a moderate dose of norepinephrine, 0.33 mics per kilo per minute. The blood gases showed both hypoxemia and hypercapnia. The CO2 partial pressure was 6.7 kilopascals, that's approximately 50 millimeters of mercury, but as I mentioned before, the lactate was in the normal range. Doppler showed a low normal stroke volume of 39 mils, a cardiac output of 4.3 litres per minute, however, a very narrow corrected flow time, and again, a big respiratory swing. This also implies underfilling of the left ventricle, so there are a number of causes to consider. There may be an absolute hypovolemia or a relative hypovolemia due to, for example, obstruction. So could he have a pulmonary embolus? Could he have tension pneumothorax? Or could there be right heart failure, so the blood isn't being pumped from right heart through to the left heart? On the other hand, could these ventilator settings be responsible? Could he have too much auto PEEP, too much intrinsic PEEP? So going through these possible differential diagnoses, he had a straight leg raise that showed no improvement in hemodynamics, therefore making hypovolemia less likely. There was clinically and on an X-ray no obvious pneumothorax. There were no ECG changes of note denoting acute right heart strain, and playing with the ventilator, decreasing the PEEP from 14 to 7.5 gave an immediate large improvement in tidal volume, an improvement in saturation, an improvement in hemodynamics with a stroke volume going up from 39 to 57 mils, and an improvement in blood pressure. After playing a bit more with the ventilator, normalizing the IE ratio, there was an improvement in gas exchange, and the carbon dioxide level came down to the normal range. The improvement in hemodynamics also allowed the norepinephrine to be reduced from 0.33 to 0.1 micrograms per kilo per minute. So the learning points here are that, again, like the first patient I showed you, there was a low stroke volume, a low corrected flow time, and a big respiratory swing. However, in this case, it was an iatrogenic cause. The ventilator settings were such that there was a very high level of intrinsic PEEP, which stopped blood getting through to the left ventricle. So correcting this iatrogenic anomaly improved his tidal volumes, improved his circulation, and allowed a big reduction in the norepinephrine dose. So I hope you've enjoyed the last few minutes of me talking and illustrating a few interesting hemodynamic cases. Thank you very much for listening. Bye-bye.